Hello, JACC listeners. This is Ed Gerstenfeld. I'm from the University of California, San Francisco. I'm here with Mark Tam from the Chinese University of Hong Kong. And today we're going to discuss his paper. It's due to be presented at the upcoming Heart Rhythm meeting in San Diego and also with a simultaneous publication in JACC. Really excited about this paper. It's titled Effect of Pulsed Field Ablation on Human Coronary Arteries, a longitudinal study with intra-coronary imaging. So welcome, Mark. Thanks for joining us today.
Thank you, Dr. Gerstenfeld, and thanks, JACC, for this opportunity.
So maybe you can just give us a little bit of background, Mark, in terms of what led you to perform this study.
Yeah, sure. So we actually had the idea of starting this study right from the very first case when we used PFA to do AF ablation, because the PFA energy is so convenient in achieving PVI. It's very tempting to use the very same catheter on doing atrial flutter ablation as well. So we have been trying to use it on CTI ablation and HRS ablation. And of course, we also observed the coronary spasm that a lot of the other experts has reported. And sometimes we do observe very significant coronary spasm despite we gave preemptive TNG. So that make us think, okay, so we can tackle the coronary spasm with TNG, but would it translate into a longer term problem with coronary stenosis? And I think that's a core question that we want to answer.
Yeah, fantastic. I think everyone's excited about PFA, but some have said, coronary spasm is kind of the Achilles heel of PFA. So I think this is a really important study. This is your study diagram from the paper. Maybe you want to take us through what you did in your study?
Yeah, so I think the specific thing that we want to do in this study is that we want to do serial imaging, coronary imaging for all these patients. So what we are going to do is we recruited 19 patients who underwent PFA for atrial fibrillation ablation. And after AFib ablation, they are planned for CTI ablation or mitral ablation. So before they underwent the atrial flutter ablation, we gave all these patients intra-coronary nitroglycerin and performed the first run of coronary angiogram and OCT as a baseline. And then we proceed with the ablation in flower pose for both the CTI and mitral isthmus with 2 to 3 applications at each site and 2 to 4 sites to create linear block across the CTI or mitral isthmus. And along the ablation, we shoot a serial coronary angiogram and try to check for spasm. When we identify significant spasm, we will repeat a second run of OCT. And then after 3 months, we will bring all these patients back for a third run of coronary angiogram and OCT to check for the chronic sequelae to the coronary arteries.
Fantastic. And this is all with the pentaspline PFA catheter.
Yep, that's correct.
And can I ask, because we're used to giving intravenous nitroglycerin before ablating, but you actually gave intracoronary. What kind of dose did you give, and why did you choose intracoronary as opposed to intravenous?
Yeah, so in a few pilot patients, we tried intravenous nitroglycerin. We actually tried to copy the dosage that Dr. Vivek Reddy has published in a circulation paper, like 1 to 2 milligram of intravenous nitroglycerin, but that was proven to be too high a dose for our Asian patients. And still, we do observe some quite significant spasm despite intravenous nitroglycerin. So because we're going to do coronary angiogram and OCT anyway, we will have a catheter engaging the coronary artery. So I think it is more effective to give the intracoronary nitroglycerin. So the dosage that we gave is, the mean dosage was 800 microgram. And it is comparable to the dose reported by Vivek Reddy's group.
Perfect, perfect. And then this is your central illustration. So maybe can you take us through what you found in your study?
Yeah. So in the left panel, you can see two plots. In the left-hand side, you can see the vascular wall area before ablation and at 3 months. And you can see that at 3 months, there is a median increase in vascular wall area by 17%, which is likely corresponding to the intimal hyperplasia or media fibrosis caused by the PFA, as reported in previous animal study. And in the right chart, you can see the luminal area also reduced after at 3 months by a median of 10%. And in the right-hand side, you can see a particular patient with quite significant coronary stenosis at 3 months, which can be seen in both the coronary angiogram and also in the OCT.
So pretty impressive, but I guess some could argue, well, 10%. Does that, you think, clinically relevant? Does that mean anything for these patients long term?
Yeah, so that's very true. I think 10% may not be relevant for a lot of patients with normal coronary angiogram. But if we're thinking about ablating in patients who are having a lot of vascular risk factors, if we do not do any baseline coronary angiogram, there will bound to be some patients with like underlying undiagnosed coronary artery disease. And with that, and a further reduction of luminal area by just 10% may become clinically relevant for these patients. And importantly, this study only perform OCT at 3 months' time. We do not know whether all these lesions will progress or regress down the road. So I think it is still give us a very important message that we need to watch out for the chronic problem to the coronary arteries when we are ablating around the vessels.
Yeah, and I'm noticing these lines. So one patient had quite a significant drop, right, with like a 60% narrowing. Did that patient have symptoms? That's the patient that's shown here with the stenosis.
So that's a patient that's seen shown in the right-hand side. That's the patient with significant stenosis, and all these 19 patients did not report any coronary artery symptoms. They do not have any myocardial infarction or unstable angina down during the follow-up.
Fantastic. So based on this, I guess comment on any sort of next steps in terms of further research in this area, and also what's your clinical practice? Do you still use the pentaspline catheter for flutter ablation, or have you changed?
Yeah, so I think these data tell us that we need to be very cautious if we decide to use PFA around the coronary artery. So we would, for me now, I would at least counsel the patient of the potential like and rather unknown long-term sequelae to the coronary vessels with the use of PFA. And I think I would argue that we should at least do some baseline coronary workup if we are deciding to do PFA for CTI and mitral isthmus. Because if you imagine if these patients have, like, for example, a left main lesion that is undiagnosed, and we are creating like RCA, coronary spasm, that could be catastrophic.
Do you
And
think,
yeah.
do you think RFA is safer or in terms of energy?
Yeah, it's difficult to tell. So, RFA has a lot of safety data to back up its long-term safety around the coronary vessel, but we do see like rare cases of RFA causing like coronary spasm or even long-term coronary stenosis. So I think based on these data, we cannot conclude whether PFA is safer or less safe compared to RFA. I think it is important to perhaps in the future do a controlled study with RFA to see if the stenosis that we observe is specific or more significant with PFA or RFA. And the other important research that we're trying to do as well is we want to bring these patients back for a like longer term follow-up OCT. because that's really more important question, whether it will cause problem like maybe 2 years, 3 years down the road.
Yeah, fantastic. And just to press you on this, so you're doing a PVI for AFib with PFA, and then you happen to induce atrial flutter. Maybe you've mentioned it to the patient. Do you today, would you, having given the patient some warning, use the same catheter now for CTI, or would you pull out an RF or a different type of catheter? Just curious.
Yeah, so I think to play safe doing RF will not be wrong. It is always tempting to use the same catheter to save time and save cost. But well, because this catheter is not labeled for use in these regions, I think it is more prudent to just follow the labeling of the catheter.
Perfect. Well, thanks so much, Mark. Again, all the data up until now has just been preclinical and animal data. So really important, I think, to see this data in humans. Definitely gives us some caution using PFA around the coronary arteries. And thanks so much for your contribution.
Thank you, Dr. Gerstenfeld.